Hi everyone, I'm Amy Cueva, one of the founders and Chief Experience Officer at MadPow, an experience design firm. I also chair the design track at HX Refactored, which is a conference that brings together designers and developers to improve care. The next conference is in spring in New York. At MadPow, I oversee our health practice, where we work with organizations across the health spectrum, from hospitals to insurers, from nonprofit to government to healthcare technology companies, large and small. And in the process of helping those clients improve the quality of interaction that their consumers and patients experience, I came to understand that there are some needs that are not currently being met because they fall outside of the traditional areas of ownership, and that we need to gather together and collaborate around these unmet needs, and that will enable us to design an ecosystem focused on care. So I just need my slides, and I should be ready to go. I'm just going to cut right into it. Okay, here we go. I am a designer. In fact, I think we are all designers. We engage our empathy. We envision a positive future, and we are collaborative in our mission to get there. We're not just designing interfaces. We are designing the human experience. I believe that design is powerful and can help us to improve the human condition, and that we're measured by our impact on humanity. Some of the things I'm going to talk about, I've already heard you all talking about in conversations and in talks. And that's really exciting because it's indicative of the momentum that's building and how this connection and collaboration is going to help us and propel us forward. I'm really excited to be here talking with you today about this passion of mine, which is unmet needs. I recently had the opportunity to participate in a research study that we conducted with the recently diagnosed. And we talked with a gentleman who we can refer to as Jim for our purposes here. Jim was recently diagnosed with congestive heart disease. In the course of talking with him about his condition and how he was learning about it and how he was attempting to change his life based upon that diagnosis, he told me how the diagnosis had affected him, his life, and his emotions. He told me that he was overwhelmed, confused, and alone. He felt like he had no one to talk to. He didn't know what to do first or what to expect. I instantly felt for this man. I felt like I was there with him when the doctor told him that he had congestive heart disease. I felt like I was there with him when he really stopped absorbing what the doctor was saying because his mind was racing. I wanted the best for Jim, just like I would want for my own father. My first instinct was to squelch these emotions. They have no place in business, right? But I thought to myself, what role does emotion play in the solutions that we create? I like this definition of health from the World Health Organization because it mentions well-being. And I do believe that well-being is the foundation for health, and that a spike in emotional intensity is indicative of an at-risk individual or an unmet need. And if we address those unmet needs, we'll be able to design an ecosystem focused on care. Basically, emotion matters. Jim's as the patient, and mine as a designer and member of this health ecosystem. Jim's emotion helped me to understand that this transition was a critical point and may define the trajectory of his path forward. that his ability to care for himself and not end up in the ER may hinge upon how this situation is handled. It's in our best interest to help Jim, because when Jim is successful, we are more likely to achieve the outcomes that we seek. It's not idealism, it's good business. This situation led me to think about, okay, who do I know in industry that I can talk to about addressing this clear and important unmet need, this transition? And I thought of somebody that I knew at a hospital, and I said, hey, we need to do better. We need to help Jim. We have the resources. He shouldn't have to locate them on his own. We have the tools to support the lifestyle changes he needs to make. He shouldn't be left to find them on his own. There are community support mechanisms that we can put in front of Jim that will help him. We can guide him through this transition. Maybe we create a place that brings all of this together to help Jim. And this person shared with me that they didn't think that this was the hospital's responsibility. Now, I know many of you in this room disagree, and that's fantastic, because what we're talking about now is how to do this, how to bridge these gaps and address these unmet needs. Now, maybe this person was thinking about time and budget and roadmaps and release cycles, and that the patient website's focused on acquisition, and that the patient portal may be hard to evolve to address patient experience needs as they emerge. Maybe change makes this person uncomfortable, but I think we need to get comfortable being uncomfortable, because change is difficult, but we need to press forward. The health system functions, but it doesn't get as close to whole health as we would hope possible, considering our capacity to care, to connect, and to innovate. We're focused on the technology, the tool, the thing, the shiny object. And technology should support our efforts, but should not be our focus. Technology in and of itself won't deliver the value we seek, but how the technology connects people with meaning will. Technology should be the wind at our backs, not in our faces. Many of the entities in the health ecosystem, things are changing, but still too frequently, we're siloed both inside and outside of our organizations. Territories defined by existing relationships and transactions create gaps and obstacles and boundaries that we need to overcome. Each entity has its own objectives. However, there are shared objectives. How can we help prevent that amputation? How can we reduce this person's anxiety? How do we help this person live a more energy-filled life? How do we prevent that next heart attack? We have our own objectives, but we have shared objectives. And I got really excited about this thinking. We can break down existing walls and boundaries, and we can take an open source and collaborative approach to business. We can extend our services. We can take an open approach to working with those in the ecosystem that have shared objectives. And I shared this idea with a representative of the government, that we should design an ecosystem focused on care and put a stop to our tunnel vision and stop reinventing the wheel all over the place and really share existing resources, integrate data, leverage everything that already exists, just work together, bring it together for the patient, for the consumer. And this person told me, no, partnership is not the answer. That won't work. Now, sometimes when we try to do something and it doesn't pan out, we can become jaded. But I think there is good knowledge in failure. It can inspire us and lead us to future success and not cause us to give up. But what I heard loud and clear was no. No, I don't like no. I never have. I think no halts thinking. I think that no stifles imagination. I think that no is a barrier to innovation. No says, don't reach. Stay comfortable. Don't try. I think something better to say would be why. Why are things the way they are? Or better yet, why not? Why can't we envision a better way? Or better yet, what if? What could we create if we work together around shared objectives? So as you can see, I'm very passionate about this topic. I've been spending a lot of time considering how do we identify and address unmet needs? And I have some ideas that I'll share with you, but I'm interested in seeing how these things evolve in the next few years. I think that addressing these unmet needs hold the key to designing an ecosystem focused on care. First and foremost, research. Research is the core of human-centered design. It helps us understand the people we're designing for. It helps us walk in their shoes and understand the context of our lives. And when we have that understanding, our solutions are more likely to provide the results we're seeking when they're active in the wild. Research can inspire the solutions we create. We can also leverage human-centered design, design thinking, collaborative design, participatory design to involve those who are affected by the solutions we create in the process of creating them, and the results will improve. And then there are other techniques like usability testing, usefulness testing, and desirability testing that will help make sure that the ideas we thought were brilliant in a conference room will actually work in the field. I do think that we need to allow ourselves to feel. In the conference room, in meetings, in research, in clinical service. Our emotion will guide us to the answer. When we feel a pain point again and again, we can become hardened and start to think that it's something that can't be changed. I think if we let our emotion smack us in the face and sit with that feeling, it can drive our curiosity, it can inspire our imagination, and can lead us to take action. I think empathy holds the answer. Some of the outputs you might see post-research are personas and mind maps and mental models and storyboards, journey narratives. You might see a journey map like this. These journey maps help us to explore the interplay of emotional intensity, pain, anxiety, loneliness, or a dip in engagement that may be indicative of an unmet need with the health status and the health journey and the life journey. Who are people talking with? What entities are they interacting with? And how do we fit into that picture? Journey maps can also help us envision a positive future. A colleague of mine calls them idea experiments. They enable us to formulate concepts and run them by others to see what they think. I also think we need to take a step back and widen our lens. Sometimes we're so focused on the specific situation at hand that we're missing out on opportunities to connect. For example, pre-visit, preparing someone for the visit, during the visit, and post-visit. How is this going to create meaning and value in their lives? We can look for feelings because they're good clues to what's going on and what needs to be done. Triggers, when should we communicate? When should we intervene? Transitions, life transitions like death, divorce, new baby, moving. Health transitions like a change in status, new diagnosis, new medication, new treatment. Or system changes like a new insurance plan, bills that somebody might not understand, or a stack of paperwork. We can also look at opportunities and patterns. If we see something repeating, we can put systems in place to predict and react and influence many. I think there are 3 types of unmet needs. I didn't know, which is a health literacy or awareness issue. But there's so many community support and health literacy programs. How do we connect people with those? Or I know I should. I know I should eat better. I know I should exercise more. This is indicative of a lack of motivation. We're seeing so many behavior change programs and applications hit the marketplace, some of which have been clinically proven to improve outcomes, which is so exciting. There's actually a panel tomorrow on behavior change discussing what really works. How can we really help people change their behaviors? And I want to, but I can't. This is indicative of a lack of resources, whether it's money or insurance coverage or access or translation services. I think we can list out the needs that people have and see how they map to entities in the ecosystem. And if there are needs that are not being addressed, figure out how we can reach and extend our services and collaborate with organizations that have a shared mission to get there. For example, heart health or diabetes. Who is working on that? What resources can be leveraged? How can we work together to bridge gaps? I recently saw Cindy Gallup speak. She's a provocateur in the advertising industry, and she said, shared values plus shared action equals shared profit, financial and social. This couldn't be more true than in health. And we can change things from I didn't know to I know, to I should, from I should to I will, and from I can't to I can. We're working on some of these very challenges at MadPow. For the informed medical decision making, working on awareness and health literacy, helping pregnant women make decisions as they move through maternity. And with CVS, helping people along their path to better health by addressing some of these unmet needs and providing a level of support that may not be accessible elsewhere. And with Joslin Diabetes Center, bringing their well-established in-clinic diabetic weight loss program online so that more people can have access to it. This is going to integrate into the clinical setting soon and move to clinical trial at some point next year. And as you all know, sitting is the new smoking. This app is designed to get people up out of their seat throughout the day, and recently went to pilot with the American Heart Association and was proven to do just that. Yay, results. We're doing some amazing things. Other things are happening, like health insurance companies are setting up platforms that healthcare technology companies can plug into and magnify the possibilities and the access to patient populations to start to prove that this stuff works. Patient experience teams inside hospitals are looking at how to extend beyond the hospital walls to help people manage their conditions and be healthier. Great things are happening, but we can do more. I challenge us all to involve those who will be affected by the solutions we create in the process of creating them, to engage our empathy, to collaborate with those who have a shared mission outside of our department and outside of our organization. I believe we can partner up together and design an ecosystem focused on care, and we can do it for Jim and for people like him. Thanks so much.